Hello everyone and welcome to this video lecture on Chapter 22 on the respiratory system. We'll start by describing the respiratory system itself. This system is going to help us move our gases into and out of the lungs and also is going to exchange the gases between the alveoli. Those are the air sacs within the lungs here that look like the little balloons, and the capillaries that are going to reside right next to them. And these capillaries will then help to move the blood, the oxygenated blood, I should say, through the vascular system and take it over to the oxygen-deprived tissues to then offload that oxygen into each of those cells. So that's an overall look at the role of the respiratory system, but what are individual functions? First, they are going to help us with the regulation of blood pH, and we do this by changing the blood carbon dioxide levels, so we'll get into more specifics there. We also are able to produce a chemical mediator known as ACE, an angiotensin converting enzyme. It'll help us with voice production, where we're able to move the air past our vocal folds within the larynx, and the larynx is part of that Adam's apple that you feel in the front of your neck to help produce sound and also assist us with speech. And we also have the ability of olfaction. That means that we're able to smell using airborne molecules that we pull into our nasal cavity. It makes contact with our mucous membranes and then will travel up eventually through our olfactory nerve, which is cranial nerve number 1. And lastly, it assists us with protection. We know that microbes are always trying to move into our body, and so having our nasal passages there, and yes, we're able to inhale through our mouth as well, having some lymphoid tissues such as our tonsils there, it will help us to prevent that entry and help remove the pathogens from our respiratory surfaces. So let's start getting into the anatomy of the respiratory system. We divide our respiratory system into 2 different tracts. We've got our upper respiratory tract, which is going to be the anatomy within our head and neck. It starts off at our nasal cavity, then moves into the nose itself and into the nasopharynx, which is back over here, and into our oropharynx, which is going to lie right below here, still as a part of our pharynx, and then into the laryngopharynx, and finally makes its way anteriorly to the larynx. The other tract is called our lower respiratory tract, and so we find this anatomy more in the thoracic cavity. Continuing down from the larynx, we then are going to move into the trachea and into our main bronchi. That's going to enter the substance of the lungs, and we will see a bronchial tree there that we will talk about more in detail, the different branchings of that, until we make it into the alveoli, the little air sacs that look like balloons. So note that the previous slide, we really divided up the respiratory system structurally based on if it's toward the upper half or lower half. The other way we can divide out the respiratory system is functionally. So the upper passages are going to be known as the conducting zone, meaning we're moving the air through the respiratory structures and no gas exchange is taking place. And then beyond the area known as our respiratory bronchioles, we will call that our respiratory zone. So I'll reference that once we get to it. But first, let's talk about how are we getting this air into our body. So the first way is through our nose. And we said that this is going to serve as a protective quality too, in allowing us to move that air in and remove some of the debris or any pathogens. And as that air moves in, we are going to warm and humidify it. Now our nose is made up of some nasal bones that we're going to see up at the top here, Or in the sagittal view, we can see the nasal bones over here and a series of nasal cartilages. You could see these outer cartilages help to shape our nose here, but it also extends inward. So here we see our septal cartilage coming together with two bones known as the perpendicular plate of our ethmoid bone and the vomer. Last thing to mention here is that we have these outer wings of the nose that help form our nostrils, and these are called the nares. Now let's look a bit more internally and take a look at this sagittal view. At this point, we have gone more lateral, so we are not seeing the perpendicular plate in the vomer and that septal cartilage that makes up what we call the nasal septum. Instead, we are looking along the sides of the nose, of the nasal cavity, I should say, and we could see it is lined with a mucous membrane here. This membrane is used to warm and moisturize our air and assist to also remove debris. Notice how we have a bit of this rocky look to it, and these are called nasal concha, and they help to provide extra surface area. So if I were to slice the nose like this, actually a little further back, more like this, then we would see this view here. And so we could see the concha are the parts that are creating these grooves in here, and are one made up of bone, actually different types of bone, and we'll get into that a bit more later. And then we are also going to create spaces under there known as the meatus. Remember, the word meatus means canal. And within these areas, we are creating vestibules. This is that anterior part of the nasal cavity that is going to be lined with that stratified squamous epithelial tissue, and we've got these stiff guard nose hairs here that will block the debris from entering our nasal cavity and our respiratory tract. Now let's move into the pharynx. We talked about our nasal cavity here, and if we move posteriorly, that brings us to one of three subdivisions of our pharynx known as the nasopharynx. So the nasopharynx, by definition, is posterior to the nasal cavity. And then we have our oropharynx inferior to that. That is defined by being posterior to the oral cavity. And lastly, we have our laryngopharynx, which is posterior to our larynx. Now, the epithelial tissue here is going to vary in the pharynx based on the materials that travel through each area. Continuing on down from the pharynx, and actually let me back up really quick here. Since we're breathing air in, this epiglottis, a part of the larynx, is going to stay up for the air to move in anteriorly here. If we were to ingest any food or fluid, this epiglottis would move down and the food and fluid would move backward into the esophagus. So let's talk about that larynx a bit more. The larynx is known as our voice box and is made up of cartilage. So this will contain two important vocal cords. And we can see them pictured over here. And I'll show you one more view in a coming slide. So the pink here is going to be known as our false vocal folds, also called our vestibular folds, and they are going to be used more for creating intrathoracic or intra-abdominal pressure, whereas our true vocal folds or cords here in the whitish gray color, those are known as our ventricular folds, and they are our true vocal cords to vibrate in order to produce sound. Now, the other cartilages that we see here, I'm going to point out in this anterior view first. If you slide your hand further back right along the bottom of your chin, you will feel your hyoid bone. You move a little bit further down, you're going to feel your thyroid cartilage. This makes up our Adam's apple. Notice how posteriorly it is open. It does not connect. Whereas our cricoid cartilage that we find inferior to that is going to make a complete ring around the entire larynx organ. Then we've got some smaller pieces of cartilage. Our arytenoid cartilages we can only see from the posterior view here, and they are these triangular pieces over here. Sitting on top of the arytenoid cartilage, we see the corniculate cartilage. And I always think these are a little sharp looking, so you could stick a little corn on the cob in that sharp little piece over there. How are we going to be able to produce sound? We don't see it in its true illustration in these images, but we are going to have some muscles surrounding this area of the larynx that will allow the vocal cords to move, and like we said, they will vibrate to produce that sound. And then we'll reference the epiglottis again. In the anterior view we can't fully see it, but posteriorly you could see that leaf-like shape that it has. As we said before, this is able to swing on down in order to block the entrance of the trachea when we swallow, so food and fluid can move backward into the esophagus. Let's now take a little bit of a closer look at where those cartilages lie. So first will be your thyroid cartilage. This is that large shield-shaped cartilage that is going to contain right here that laryngeal prominence and is known as the Adam's apple. Our cricoid cartilage sits inferior to that and is ring-shaped. Then posteriorly, we are going to have those arytenoid cartilages that you see in pink there, and sitting right on top are your corniculate cartilages. And lastly here, we have your epiglottis. Now, if you were to take a look at the larynx in actuality, you would see that it is completely covered with this mucous membrane here. And so we are going to have these bumps serve as where we would imagine the arytenoid cartilages, the corniculate cartilage, and then also floating right above that, you'll see one more bump known as the cuneiform cartilage, which we're indicating here as the cuneiform tubercle. And here's another look at that cricoid cartilage with the thyroid cartilage out of the way. Note that it is a complete ring and that it is more narrow anteriorly and wider posteriorly, almost like a class ring. And just another view of that epiglottis from a sagittal view. We see the epiglottis over here. It is made up of elastic cartilage, not hyaline cartilage, and can cover up that laryngeal inlet during swallowing to prevent that food and fluid from moving down into the trachea here. Now for voice production, we know that our speech is going to be an intermittent release of expired air, meaning we're breathing in during the opening and closing of the glottis. Our chambers of our pharynx, the oral cavity, our nasal cavity, and sinus cavities are going to help to amplify and enhance this sound. And our pitch is going to be determined by the length and tension of our vocal cords, and the loudness will depend on the forced air there. So then our sound will be shaped into language using muscles within our pharynx, tongue, and soft palates, and our lips. So let's go ahead and watch this video as to how these vocal cords are going to be put to work.
Now give me a singing. At a low pitch and then sing up. Okay, can you go any further? Okay, good. And now high to low. All right, say hee.
It's truly remarkable what our larynx does for us. So from the larynx, here you could see the cricoid cartilage, we are then going to move down into the trachea. And our trachea has about 18 to 20 C-shaped cartilages that will hold it open so that we can have an easy passage of air move down to our main bronchi over here. Our trachea, like we said, will help split into these main bronchi, which are sometimes called the primary bronchi. And if we look at the inner lining within the trachea, we would see that there are ciliated epithelium to help trap debris from accumulating in the lungs. And here's another view of what the trachea looks like. So notice that the trachea has that C-shaped cartilage here. The lumen is in the center to allow air to move through, and posteriorly we see the esophagus. Here's a view of what the epithelium looks like in the trachea. It's made up of our ciliated pseudostratified columnar epithelium, and this is an actual histology view where we see the cilia. And notice that sitting in between some of these cells, we've got these goblet cells, which are going to help to produce mucus. And that mucus helps move debris over toward the pharynx so that we can either swallow it or cough or sneeze it out. And here's another histology view where we see the cartilage, and we're going to have this connection between the two ends of the C shape of that cartilage, known as the trachealis muscle, and then posteriorly we see the esophagus. Now we've made our way past the trachea and are going to start moving into the main bronchi and into the bronchial tree. We're still in the conducting zone here, meaning no gas exchange is taking place. So moving through the main bronchi here, we're going to enter the substance of the lungs. From there, we're going to start to subdivide into what we call the lobar bronchi or secondary bronchi. And these will go into each lobe within our prospective lungs. So our left lung is going to have 2 lobes, and our right lung is going to have 3 lobes. And I'll show you these lobes in an image coming up. And this really is because of the position of the heart sitting slightly over on the left side. So we do not have as much room for the left lung to have more than these 2 lobes. And so the 2 lobes that we would find are here and here. Now note that we have these deeper segments here, or smaller segments. These are going to be called our bronchopulmonary segments, and our secondary bronchi are going to branch into now the segmental bronchi or the tertiary bronchi that will go and supply each of these bronchopulmonary segments. While we're talking about bronchi, we have to mention that these larger bronchi and the bronchioles will have smooth muscle within their walls, and so they are able to do bronchoconstriction or bronchodilation. Bronchoconstriction is going to be when our smooth muscles in here are going to contract and our airways start to narrow, and therefore they're restricting the amount of air passing into and out of our lungs. Sometimes this is going to lead to more mucus production as well. So you can see here that it is more controlled through our parasympathetic autonomic nervous system. Whereas our bronchodilation is when we are going to allow that smooth muscle to relax and allow our airways to widen, which will allow air to pass into and out of your lungs much more easily. And this is controlled through our sympathetic autonomic nervous system. So we move through those bronchi and we get into your smaller bronchi, which are called bronchioles. And soon we'll end up at your terminal bronchioles. That will be the last part of the conducting zone. So there we have your terminal bronchioles. And notice that these areas still have some smooth muscle associated with them. From the terminal bronchioles, we are then going to branch into respiratory bronchioles. And this is where our respiratory zone begins, because this allows us to now have gas exchange take place. From the respiratory bronchioles, we are going to divide into alveolar ducts, which then are going to have our alveolar sacs associated with them, which will contain many alveoli. And they are the individual balloon-like structures here, our air sacs. Our alveolar ducts, like I said before, are going to give rise to more alveoli. And our alveolar ducts will lead to the alveolar sacs, which are going to have 2 to 3 alveoli at the very end here. Now at this point we have no cilia, but debris in here can be removed by macrophages. I in fact like the other name for these macrophages, which are called dust cells or alveolar macrophages. The macrophages are able to then move by nearby lymphatics and into our terminal bronchioles to continue searching for pathogens or debris. Now let's take a look at this tissue more deeply. Here we have one of our alveoli, and we are going to create something known as a respiratory membrane. So this is an important concept to understand because it'll be important in understanding some of the pathology that could take place within the lungs later on. So note that this is our alveolus, like we said, and this here is our capillary. And so sitting between these areas here is our respiratory membrane. We have another respiratory membrane here, another respiratory membrane here. And we divide this out into 4 distinct components or layers of our alveolar capillary membrane. First is going to be that surfactant layer. So you see it a bit in the light blue over here. It lines our alveolus, and this is going to be a phospholipid that is going to help lower our surface tension in the alveoli. Otherwise, it would collapse, meaning that if we didn't have surfactant here, we would have some water, and water molecules are attracted to one another. And so with surfactant being here, it helps pull those water molecules apart a bit more and allows the alveolus to stay nice and open. Moving into our second layer here, we call this the tissue layer or the cellular layer. And here we're going to see that our alveolus is made up of our simple squamous epithelium. We are going to call these our squamous pneumocytes or type 1 pneumocytes that will allow for easy gas exchange to move through because of its thin cell layer. The other cell we see here are going to be our great alveolar cells, also known as our type 2 pneumocytes or granular pneumocytes. These will help to produce the surfactant that we find in the first layer and will help aid in cellular repair. Our third type of cell will be our alveolar macrophages that I mentioned earlier. These are also called type 3 pneumocytes, wandering macrophages, or dust cells. And their job is to go through and ingest foreign particles as they wander through the alveoli. The last thing I'll mention here is that we are able to have our alveolar macrophages move between different alveoli through these pores of Kohn, or known as alveolar pores. These are just smaller holes that we find between the alveoli so that we can go in search of debris. Now for our third layer is the interstitial space here, and this is going to separate out the alveolar epithelium, so the wall of the alveolus, from the basement membrane and capillary endothelium that we have here. So this should contain just a little bit of interstitial fluid, but if you can imagine more fluid accumulating in here, known as pulmonary edema, that is going to make that gas exchange much more difficult. Like we said, we want the space to be small so that we are going to almost see that the alveolus and the capillary are fused together. When fluid accumulates here at the interstitial space, we can also call this interstitial edema. And our fourth layer is going to be made up of our capillary endothelium, and this is going to contain our blood, which of course has our red blood cells in there. So just to go through these layers again, our first layer is going to be that surfactant layer. Then we are going to have our tissue layer, which contains a lot of our cells, like our type 1 alveoli, our type 2 alveolar cells, and our type 3 macrophages. We also are going to have layer 3, which consists of our interstitial space. And lastly, our endothelial layer. And again, this creates our respiratory membrane in order to allow gases to move in between our alveolus and the capillary. Now let's talk about the lung organ itself. We have two lungs, which are going to be our principal organs of respiration, and each one is going to have an apex, which is going to be this rounded superior end of the lung, and a base at the bottom that is going to sit against our diaphragm. If we look at the medial surface, we would find a hilus, and that is going to be where structures enter and exit. Our right lung, like we said, has 3 lobes, and these lobes are separated by fissures. You can see the fissures over here, and we'll learn the name of it in just a moment. And our left lung has 2 lobes, and we'll see in another view that cardiac notch for the heart. So here we are taking a look at the medial view of the lung. Here is the hilus or the hilum. This is going to be where our root of our lung can be found. In that root, we are going to find that we have a pulmonary artery, which is a branch from the pulmonary trunk that can bring in our deoxygenated blood from the heart into the lung. We are going to have 2 pulmonary veins that are going to carry oxygenated blood from the lung back to the heart, and specifically empty into the left atrium. And lastly, we will have 1 primary bronchus, which is a branch of that trachea and will serve as a passageway of air. Note that our lungs are going to be perfused by 2 circulations. We have our pulmonary circulation, which involves our pulmonary artery and veins, and then we have our bronchial circulation, which is going to give blood supply to the lung itself. Now, taking a look at this right lung, we said we have 3 different lobes. Our first lobe is going to be known as the superior lobe here, sometimes also called the upper lobe. Then we have our middle lobe, and lastly our inferior lobe, or sometimes it is called our lower lobe. And these lobes are separated out by fissures. So first I'll show you this horizontal fissure. This is helping to divide out our superior lobe from our middle lobe. Then we have our oblique fissure here that is separating our superior and middle lobes from the inferior lobe. And then a note here that our right lung is larger, with 66% of gas exchange taking place here. Now, of course, we have to take a look at our left lung now. This is made up of 2 lobes, so we will have our superior or upper lobe and our inferior or lower lobe. Now, this is just divided by 1 fissure, known as our oblique fissure. And if you remember, that word oblique means diagonal. So this is just a diagonal fissure separating the superior lobe from the inferior lobe. We also have a unique feature here known as the lingula. This is found on the inferior aspect of the superior lobe, and it looks like a little tongue that is going to hang over the apex of the heart. Some say that this is remnant of a 3rd lobe that used to exist. Now, we mentioned that the left lung is smaller because of the position of the heart closer to the left side of the thorax. And so this creates a cardiac notch here that is going to create a concavity for the heart to fit into. Now let's talk about the pleura of the lungs. If you remember, we've talked about pleura before, and this is going to be a thin, double-layered serosal membrane that is going to divide our thoracic cavity into two pleural compartments and mediastinum. So we will have some membranes lining the thoracic cavity. Histologically, if we look at this, we see that double layer, and it is going to help surround each of our lungs here, and we're going to subdivide this into different names depending on where they are located. So first we will have our parietal pleura, and this is going to line, let me get everything up here, the internal surface of our thoracic wall. So if you look here, we see our ribs, and lying between them are intercostal muscles and membranes. And so that parietal pleura, which the word parietal means wall, is lining the wall of our thorax. And notice how this is covering surfaces not only on the thoracic wall, but also the superior face of our diaphragm down over here, and around our heart, which would lie over here, and the area of our bronchi and our apex. Then we have our visceral pleura over here in the orange, and this is going to be the serous membrane that is going to line the surface of our lungs and is adjacent to the external surface of our lungs. Now, sitting between these two pleural layers will be our pleural cavity, and this space is going to contain pleural fluid. And this is so we can provide lubrication and surface tension that will assist us in our expansion and recoiling of the lungs. If we did not have that fluid in there or built up pressure air in here, that could cause the lung to collapse. We could also possibly have too much fluid in here that could put pressure on our lung, causing it to collapse as well. Typically, when we have any excess fluid here, we have our lymphatic system, which would lie right around in this area, pull that fluid in order to take it back to our venous system. And I also want to draw your attention to this area we call the mediastinum. This is a central region here that is going to contain contents of the thoracic cavity except for the lungs. So we would include things such as the heart, the aorta, the esophagus, and the great vessels that come off of the heart. Next, let's talk about the process of breathing. As we said, we have ventilation take place, where basically we're just moving that air into and out of the lungs. We are not necessarily talking about gas exchange taking place. So air is going to want to move from an area of higher pressure to an area of lower pressure. If we have that barometric pressure greater outside here in the environment than our alveolar pressure that we have within our lungs, then our air is going to want to flow into the alveoli. Our diaphragm then is going to contract, which flattens it out, and the size of our alveoli are going to increase. Let's talk about some of the muscles that help us with respiration. When we have our muscles that help us expirate, really our diaphragm is going to be put to work, not put to work, but actually the opposite. It will have us relax. So it creates this dome shape to it. I almost like to think of it as creating that dome puts pressure on the lungs to help push that air out through our mouth. And if we were to have some forced expiration, we would also have our internal intercostal muscles assist with making our thoracic cage smaller so we can push that air out. We can also call upon some of our abdominal muscles like the rectus abdominis in order to further push air out of our body. Now, when we inspire, we are going to have our diaphragm contract, creating more of a flat muscle rather than dome-shaped. We can also call upon our external intercostal muscles, And if we were to have forced inspiration, we can call upon our pectoralis minor muscle and some of our neck muscles such as the scalenes and the sternocleidomastoid muscle in order to make our rib cage larger to allow more air to move into the lungs. And then we would also want to relax our abdominal muscles. So let's review what we just talked about on that previous slide. Our muscles of inspiration will include our diaphragm, which we see pictured here, and this is a inferior view of the diaphragm. So you are basically in the abdomen looking up. And then we have our external intercostal muscles that we will find sitting in between the ribs here, and our pectoralis minor muscle, as well as those scalene muscles in the neck. Like we said, when we are inhaling, our diaphragm is going to want to contract. So it is going to pull downward so it is flat shaped. Notice how we have that diaphragm sit along the entire circumference of that inferior thoracic cage. And in the center here, we have what is known as the central tendon. When we are sitting here quietly, we have quiet inspiration taking place, and that is going to account for 2/3 of the increase in size of our thoracic volume. Then we have that inferior movement of our central tendon and a flattening of that dome shape, as we said, and our abdominal muscles, such as our rectus abdominis and our obliques, are going to relax. Now, when we take a look at our expiration muscles, that will include our muscles that we see depressing the ribs and the sternum. So that would include our abdominal muscles, as well as our internal intercostal muscles sitting in between the ribs here. When we have quiet expiration taking place, our diaphragm relaxes, and this creates a dome shape that we see here. Our external intercostals, as well as our abdominal muscles, though, will contract. When we are in labored breathing, all of our inspiratory muscles are going to become active and contract more forcefully, so expiration will be rapid. Now here's a look at what is happening to our ribs and our sternum as we are breathing in, going through inspiration in order to increase the size of our thoracic cavity. You could see that our ribs move up kind of like a handle on a bucket, and our sternum is going to move more anteriorly and a bit superiorly in order to, again, increase the volume within our thoracic cage. Next, let's talk about Boyle's law. This is a relationship that we find between pressure and a volume of a gas. As our gas always fills a container, we see within that container that our gas is going to want to move around, right? So as we are increasing the volume or the space in here, we will see a reduction in the pressure. But if we were to kind of pull this cap down here, decreasing the volume that that gas has to move around and bounce off of each other, we increase the amount of pressure. So noting this relationship, we could say that pressure varies inversely with the volume, and mathematically could be represented as pressure 1 multiplied by volume 1 equals pressure 2 multiplied by volume 2. Now that we know Boyle's law, let's talk about our process of breathing when it comes to pressures. So first, let's discuss the intraalveolar pressure, which is the pressure of air that we have within the alveolus itself. This is going to change due to our different breathing phases. This is also called our intrapulmonary pressure, whereas we have our intrapleural pressure, that is going to be the pressure of the air within our pleural cavity. Remember, that is found between our parietal pleura and our visceral pleura. And that's going to be similar to our intraalveolar pressure. our intrapleural pressure will change during the different breathing phases as well. We'll see that the intrapleural pressure is always going to be lower than or negative to our intraalveolar pressure, and therefore also our atmospheric pressure. So we see that it kind of sits between or approximately at 4 millimeters mercury. So at the end of expiration, let's imagine that we are pushing all of the air out of our lungs. We see that our intraalveolar pressure is equal to our barometric pressure outside of our body. So there is going to be no air movement here. Now during inspiration, we increase our thoracic volume, and so we are bringing that air into the alveolus. So here we have an increase in our alveolar volume, while we are going to see a decrease within that alveolar pressure. So here we see that our pressure in the alveolus is going to be lower than our pressure in the air outside of our body. And so that will help to bring in the air into the alveolus. Now, once we bring all of that air in, we are then going to change our pressure in our alveolus to 0. So once again, our barometric pressure and the pressure inside our alveolus are the same, and so we are going to have no air movement. Then we want to push that air out. So during expiration, we are going to decrease the volume because we're breathing that air out, right? And so now this is going to increase our alveolar pressure. We can see it move to a 1 here, which is going to be larger than our barometric pressure. So because the pressure is lower outside of our body, the air wants to move out through our trachea, out of our body, and into the atmosphere. Now let's talk about spirometry. That is going to be a system in which we are going to be able to measure our lung volumes and capacities. And in doing those measurements, we're able to get a good reading on compliance, which is going to be how well our lung is able to expand and then return back to its shape. When we see decreases in compliance, it is a sign that we do have chronic obstructive pulmonary disorders known as COPD. Now, when we use a spirometer, which is the device that helps us measure these volumes and capacities, we are going to get a readout that looks like this. And so looking at this area right along in here, that's going to be called our tidal volume. And our tidal volume is going to be the amount of air that we are able to move into and out of our lungs in a normal breath. So as you're sitting here listening to this lecture, you are just doing your quiet breathing, and that again is called your tidal volume. So that's our normal volume, which is going to be approximately 500 milliliters, although this does vary by a person's age, sex, height, and fitness level. The other capacity that we're going to have is called our functional residual capacity, and that is going to be drawn from the expiration of that tidal volume and lower. So this is our volume that remain within our lungs after that normal expiration. Then we have our inspiratory reserve volume, which we see here in the green. This is the amount of air that we can forcefully inhale after normal inspiration. So you breathe in as you're quietly sitting here, and then you forcefully inhale as much air as possible. And this should be approximately 300 milliliters at rest, but it can range anywhere from 2100 to 3200 milliliters. And next we have our expiratory reserve volume. This is the amount of air that we can forcefully exhale after a normal expiration, and this should be about 100 milliliters at rest. Now you may be wondering, why can't we push all the air out of our lungs? That's because we have to have this residual volume, an amount of air that we leave within our lungs after maximum expiration. And that is because we need this amount of air to stay in our lungs in order for our lungs to remain inflated and not collapse. This should be approximately 1,200 milliliters. And so, excluding that residual volume, we then can measure our vital capacity. This is the maximum amount of air that we are able to move into and out of our respiratory system in a single respiratory cycle. So it is going to include our inspiratory capacity, which would include our inspiratory reserve volume and our tidal volume, our expiratory reserve volume that we discussed here, and we mentioned our tidal volume already. And here's just another image showing you what a readout using a spirometer would look like and all the different volumes and capacities that we discussed. Next, let's discuss our respiratory rate and control. When we say respiratory rate or respiratory frequency, we're talking about how many breaths is the individual taking per minute. Now, normally this should be between 12 and 18 breaths per minute in an adult. And in order to control this, we use our medullary respiratory center. We've got some dorsal groups there that are going to help stimulate our diaphragm. And our ventral groups are going to stimulate the intercostal and abdominal muscle groups. We also have a pontine respiratory group that is going to be involved with the switching between inspiration and expiration. Now, as we're breathing, of course, in those gases, we've got oxygen and carbon dioxide. Our oxygen is going to move from our alveoli into the blood through that respiratory membrane that we talked about, and our blood is almost completely saturated with oxygen when it leaves the capillary. Our partial pressure of oxygen in our blood is then going to decrease because it mixes with the deoxygenated blood, and our oxygen moves into the tissue capillaries and then into the tissues. Our carbon dioxide is going to want to leave our tissues and move into our tissues capillaries. Those capillaries will then move that deoxygenated blood containing the carbon dioxide through the vascular system and will move from our pulmonary capillaries eventually into our alveoli. Now, we've got two different types of respiration that takes place. First is our external respiration, where we have gas exchange in our lungs. I'm just going to switch back to this photo to point it out for us. In our lungs, meaning in our alveoli and our blood. So here you could see that oxygen is leaving the alveolus, entering our capillary, and carbon dioxide that was found within our blood is now moving into the alveolus so we could breathe it out. And so the other type of respiration that we have is internal respiration. This is when we are having gas exchange between our blood as well as our tissues. So here we see that our cells have accumulated carbon dioxide, so they are going to want to leave our tissues and move into the blood, whereas our blood has brought in nice fresh oxygen to give off into our tissues. So let's look at the full schematic now of how the oxygen and carbon dioxide is moving around. We'll start here as that deoxygenated blood is leaving the right side of the heart, and we see that we have a low amount of oxygen in here, but a high amount of carbon dioxide. So naturally, we are going to want to see some diffusion take place because in our alveolus, that nice oxygenated air that we were able to breathe in, we have a partial pressure of 104. So that is going to want to drive itself into the blood here where our partial pressure of oxygen is lower at 40 millimeters mercury. Our carbon dioxide is higher here in the venous end of the capillary, so it wants to move into the lungs where the partial pressure of carbon dioxide is 40. So by the time we get to the arterial end of the capillary, we could see those partial pressures equaling out. That fresh oxygenated blood is then going to travel back to the heart here. And as it's traveling back, we could start to see that we are decreasing the partial pressure of that oxygen. And that is because we are going to start mixing it with some of the deoxygenated blood, as we said, but also as we leave the heart, we will see that pressure drop because we are going to start giving off some of that oxygen to the oxygen deprived tissues. So here's an example over here where partial pressure of oxygen is high in the blood, and we see our tissues here are starved of oxygen, so naturally that oxygen wants to move through. Note that we do have to go through that interstitial space that contains some fluid in order to move into the tissues. And here we see that carbon dioxide has increased within our tissues, so we are going to want to move that into the blood as a waste product to get rid of it. So by the time that process takes place, we then get an equaling or a balance of these pressures, and then that deoxygenated blood will be carried back to the right side of the heart so we can go through the system once again. So how are we moving these gases throughout our blood? First, our oxygen is being transported and is not very soluble within our liquids. So oxygen needs a red blood cell in order to be transported through our blood. We do this using a molecule known as hemoglobin. This is going to be able to bind oxygen using our 4 heme molecules that contain this iron binding the oxygen. As that oxygen binds to the heme, it's going to further facilitate the binding of the next molecule, meaning that as I have one oxygen bind to this iron, these next iron molecules want to bind oxygen even more. The opposite is going to be true for unbinding. So as oxygen starts to leave these iron molecules, then the other oxygens are more lax and want to leave the iron as well. So how does this work? In our alveolus here, our oxygen is going to move through the respiratory membrane and enter through our interstitial space here and into our capillary. Our oxygen will then find our hemoglobin molecule and bind to the heme. We are now going to call this molecule oxyhemoglobin, meaning that it's a hemoglobin molecule that has oxygen bound to it, and it gives it a bright red color. A healthy hemoglobin level would be anywhere from 95% to 99%. Now that brings us to our oxygen hemoglobin dissociation curve. This graph here is describing the relationship between our partial pressure to the binding of oxygen to the heme molecule and its subsequent dissociation from heme. We are going to see that as we have an increase in our oxygen saturation, we can see within our tissues that this is a bit lower, but as we move into the lungs, we have a higher saturation of that oxygen. Now, when we have higher temperatures, that's going to promote hemoglobin and oxygen to dissociate faster, whereas the lower temperatures are going to inhibit that dissociation. And here's a graph that illustrates that for you. We could see at the higher temperatures here that we have more of that dissociation, so that we are going to have a lower amount of oxygen saturation as we move through the different partial pressures within our tissues. Whereas when we have those colder temperatures, we are going to inhibit the dissociation. We'll also see a Bohr effect take place. So let me switch over to this screen here for you to see this graph. This Bohr effect is the phenomenon that arises from the relationship between the pH and our oxygen's affinity to hemoglobin. So that when we have lower more acidic pH, we actually have a promotion of oxygen dissociation from hemoglobin, and this happens when we have a greater amount of carbon dioxide in the blood. And we see that the higher pHs that are more basic will inhibit the oxygen dissociation from hemoglobin. Now, what about our carbon dioxide? How is it able to transport within our blood? We do this through 3 different ways. First, we have about 7 to 10% of our carbon dioxide dissolve directly within our blood plasma, and so that's what we're seeing over here in the plasma outside of the red blood cell. It's just sitting there, and then it's able to transport into the alveolus. Then we are going to see that our carbon dioxide is able to kind of hide in our red blood cell and then out into our plasma as bicarbonate ion, and that is going to make up about 70% of our carbon dioxide. Now you could see this phenomenon taking place here in our red blood cell. We don't truly see the direction, but imagine that we had some carbon dioxide here in our red blood cell. That will then combine with the water and turn into our carbonic acid. Now it does this using the enzyme carbonic anhydrase, and then it moves into its bicarbonate ion and a hydrogen ion. That bicarbonate ion can then move out of the red blood cell and stay within the plasma until it's needed. So then this is called our chloride shift that's taking place here, because we don't want the bicarbonate ion to build up within our red blood cell. So it is going to move down the concentration gradient and be exchanged with chloride so it can move out into the plasma here. Our reaction is then going to be reversed. And so this bicarbonate ion in the plasma can then move back into our red blood cell and be combined with our hydrogen ion to become carbonic acid, which then, with carbonic anhydrase present, we are going to move into our carbon dioxide molecule again and water, and now all of that carbon dioxide can move into our alveolus so we can breathe that out. Now, when we have carbon dioxide bind to our hemoglobin, it is called carbaminohemoglobin. And this is going to be about 20% of our carbon dioxide that we transport within our lungs. And you can see its combination over here. Now, it's not going to bind to that same iron molecule that oxygen binds to, but instead it binds to an amino acid on the globin portion. So I'm going to go back a few slides to reference that hemoglobin molecule again. What it means is it's binding to this globin molecule out here, this protein, rather than the iron itself. And so when we have it bound in that globin, we are going to see a bluish purple color to the blood. Now let's talk about some modifications in respiratory functions. Some people may suffer from hyperpnea. This is going to be the increased depth and rate of ventilation to meet an increase in the oxygen demand. Now this could be due to disease, but it can also just happen from exercise. We can get hyperventilation, which increases our ventilation rate. That is going to be independent of the cellular oxygen that we need and leads to abnormally low blood carbon dioxide levels and high alkaline or blood pH. We can also see some effects taking place when we are at higher altitudes. As we go to higher altitudes, like places in Colorado or maybe on some mountains in Utah, we can get a decrease in the atmospheric pressure, which is going to make it difficult to have the same level of oxygen saturation. Some other terms would be hypercapnia, which is too much carbon dioxide. And then if we have too little carbon dioxide, that is called hypocapnia. When we have too little in our oxygen levels below our normal values, that is going to be called hypoxia. And lastly, we have apnea, which is the cessation of breathing. This is going to be or can be a conscious decision, but eventually our carbon dioxide levels start to increase, and then our respiratory centers will override, allowing us to breathe normally again. And at other times it is while we are sleeping, and the softer tissues tend to fall back and block our respiratory passages, so we are not allowed to move air in.